Well, hello there, everyone. I'm Dr. Leslie Kernisan, board-certified geriatrician and founder of the website betterhealthwhileaging.net. And this is the Better Health While Aging video podcast, where we discuss common health problems that affect people over age 60 and the best ways to prevent and manage those problems. In today's episode, I want to talk about a very common type of health problem that affects older adults, and that is kidney disease. Now, almost everybody's kidney function declines at least a little bit with aging, but it's also fairly common in later life for older adults to have something called chronic kidney disease that affects an estimated 35% of older adults. It's also possible to have what we call acute kidney injury, where the kidneys work less well temporarily or suddenly. We see that quite a lot in the emergency room and in the hospital, and that too is an issue that especially affects older adults. So I think this is an important topic for older adults and families to understand, and that's why I'm doing an episode to help you understand the basics and what's most important to know. So specifically, in this episode, I'm going to start by reviewing the basics of how the kidneys work, what they do in the body. And then I'm going to talk about chronic kidney disease versus acute kidney dysfunction, also sometimes called acute kidney injury, so you can understand the difference between those two situations. And then I'm going to get into symptoms of kidney disease, common causes of kidney disease, how we evaluate and manage kidney disease medically. And then I'll finish with what to ask your health providers. So I'm going to get started on that. But before I do, I have a very quick request, which is if you're here and you find this topic interesting, or you've been finding my video podcasts helpful, if you haven't subscribed yet, if you could please go ahead and subscribe, it would mean a lot to me. It really does help me out. It helps other people find the channel when you subscribe, and it does help support the work I'm doing. Another option, if you appreciate my making these videos, is to become a member of this Better Health While Aging YouTube channel. And to learn more about that, simply click the join button under this video. Okay, let's now talk about kidney disease in older adults. So let's start with what do the kidneys actually do in the body? So we each are born normally with two kidneys. They're here kind of in your back, kind of your mid-back, like right under where your ribs end. And their job is to continuously filter your blood and basically produce urine. Now, this might sound simple, but actually what the kidneys do is very, very involved and complicated and has huge implications for the maintenance of other parts of the body. So kidneys are actually involved in regulating your body's fluid levels and in regulating your blood pressure. So how much water you have in the body is regulated by the kidneys. Your kidneys also regulate your blood electrolyte levels of things like sodium, potassium, calcium, chloride, magnesium, and more. And they also are responsible for regulating the pH of the blood, the level of acidity in the blood, and keeping the blood within this pretty narrow range that allows the rest of our organs to function optimally. The kidneys are also very involved in removing waste products from the bloodstream, especially something called urea, which is related to the breakdown of proteins, and they also remove other waste products as well. And then the kidneys have all these other additional roles in our health. For instance, they stimulate red blood cell production through production of something called erythropoietin, sometimes referred to as EPO and used for, quote, blood doping by athletes. They also help convert vitamin D to its active form, so it can be active in the body. And then the kidneys are involved in the metabolism and excretion of certain drugs. Now, most drugs are actually, it's more common for drugs to be metabolized by the liver, but the kidneys are involved in a fair number of drugs and medications as well. And then in terms of their anatomy, so kidneys look, kind of like a kidney. There's a reason why we have that word, kidney shaped. But each kidney within it has millions and millions of these little filtering units called nephrons. And a nephron basically has two main parts. They have a glomerulus, which is like this cluster of very small capillaries where the filtration actually starts. And then they have a tubule, which actually reabsorbs needed substances into the body. And so by the time the fluid finishes going through the tubule, it has become urine. And the walls of the tubule will also secrete waste products into the fluid as well. And that's what generates urine. So the way your glomerulus and tubule are supposed to work is they are supposed to normally conserve into the body blood cells, large proteins, and glucose. So that's why later when we're checking urine on a dipstick, normally we would not find those substances in the urine. And then from each of the tubules, the urine collects into something called collecting ducts. And then it ends up exiting the kidney through a tube called the ureter, which drains into the bladder. And so each kidney drains into a ureter, and the two ureters drain into the bladder, where urine can be stored until there's a convenient, appropriate moment to release it. And if you have questions about bladder issues or urination, I actually have a video that is just about that. So your kidneys need to stay actually quite busy. They filter every bit of blood in your body several times a day when they are functioning normally. And so a normal filtration rate for an adult is generally going to be on the order of 90 to 120 milliliters per minute. And this is called the glomerular filtration rate, GFR. And as you'll see, we use that number, the GFR, later on to measure and describe kidney function. GFR does reflect both kidneys. Most of the time, people have two function kidneys. Now, some people lose the function of one of their kidneys. And what's impressive is that the other kidney is usually able to do all the job of filtering all the blood in the body by itself, although that can create a lot of work for that one kidney. So now, how do we measure kidney function? So it's generally measured through blood tests that are included in the basic metabolic panel. And if you want to know more about that blood test, I have a video that goes into that blood test and some other common blood tests. So nowadays, the basic metabolic panel does usually include something called eGFR. So that's an estimated glomerular filtration rate. There is a formula that creates the eGFR. And again, normal for adults is going to be 90 to 120 milliliters per minute. But since the kidneys are so involved in metabolizing and processing substances in the body, there are a few substances included in that basic metabolic panel that go up. They become higher than normal when kidney function declines. And so those especially are something called creatinine. The normal range for most labs is going to be 0.7 to 1.3 milligrams per deciliter. And then there's something called BUN, which stands for blood urea nitrogen. The normal value there is going to be 6 to 20 milligrams per deciliter. Now, it's important to note that creatinine is related to muscle mass. So actually, people who don't have a lot of muscle mass. So for instance, a petite older woman who doesn't have a lot of muscle, her normal creatinine level might be actually 0.6. And so that means if usually it's 0.6 and then she comes in and it's 1.1, she actually has had a significant decline in kidney function. So it's a little thing that we want to keep in mind as well when we look at those numbers. And then if kidney dysfunction becomes quite significant, then we start to see some other abnormalities on tests as well, such as excess acidity in the blood. Higher potassium levels can happen too, and we can see some other abnormalities as well. But generally, if we're just taking the initial look at how does this person's kidneys seem to be doing, we're going to be looking at eGFR, creatinine, and BUN as well. Let me now speak to the difference between chronic versus acute kidney dysfunction, because both conditions are important to know about. Both conditions can affect older adults. We might actually say that there are actually three types of kidney dysfunction that we see in medicine. So one type is what's called chronic kidney disease, often abbreviated CKD. This means long-term ongoing decline in ability of the kidneys to perform correctly. And it's defined as having either evidence of kidney damage, such as albuminuria, which means albumin. That's a common blood protein in the urine, because again, normal kidneys don't allow proteins like albumin to end up in the urine. So that would be a sign of kidney damage. Or if there's evidence of decreased filtration rate, generally considered less than 60 milliliters per minute, for at least 3 months, then we can say that the person seems to have some form of chronic kidney disease. We do have stages for that, which I'm going to show you in a moment. So this is fairly common, and it's often due to ongoing progressive damage from other chronic conditions, such as diabetes or high blood pressure, and there are some other potential causes as well. So that would be chronic kidney disease. And then there's something that is called acute kidney injury. So in this case, this is when there is fairly rapid onset. Within hours or days, the kidneys are performing much less well than usual. And it's often due to some kind of illness or problem. It's often reversible, actually, if the underlying trigger or illness is corrected. So some of the causes of acute kidney injury can include things like dehydration, especially severe dehydration, low blood pressure. Sometimes people have lost a lot of blood due to an accident or due to something else going on to their heart. Infections can cause this. Certain drugs occasionally cause this. And it's also possible to get acute kidney injury if there's a blockage in the drainage of urine. So for instance, if somebody's bladder becomes blocked and they can't pee, the urine eventually backs up into the kidneys, and that can cause acute kidney injury. So that's really the difference between chronic and acute. And so the third type of kidney dysfunction that we see sometimes is what we call acute on chronic. So that's when somebody already has chronic kidney disease, but then has one of these triggers or incidents that makes their kidneys suddenly work a lot worse than we would expect. And often those situations with acute kidney injury are things that we see in the emergency room or during hospitalization. So given that, what are the symptoms of kidney dysfunction? So when it comes to kidney dysfunction, it actually really exists on a spectrum. It can be anywhere from mild, moderate, or severe. And that's true whether we are talking about acute kidney injury or chronic kidney disease. And what's impressive about the kidneys is that even if they drop their filtration rate a fair amount, often they are still getting the job done. So mild to moderate dysfunction, even a GFR down, into the 50s, often causes no symptoms. It can actually get significantly lower than that and still not be causing symptoms. So most of the time, people won't feel anything if they are experiencing some chronic kidney disease or even a bit of acute kidney injury. However, once the filtration rate gets low enough or the kidneys are malfunctioning enough, and this means really being in the range of what I would consider severe dysfunction, this can start to cause some symptoms and significant health issues, including, first of all, signs of fluid overload. So people look like they have too much fluid in the body. This often manifests as a lot of leg swelling, or they might even start getting symptoms of heart failure. Now, I'm planning to do a video on leg swelling at one point. Most leg swelling is not actually due to severe kidney dysfunction, just so you know. It's much more likely to be due to heart failure or just kind of garden variety varicose veins leg edema. But in certain cases, when the kidneys are really malfunctioning, people can get a lot of swelling in the body. Severe dysfunction can also cause very high potassium levels, and that in itself can cause muscle weakness, muscle cramping or spasms. It can also cause irregular heart rhythms. Very high potassium is actually a method of lethal injection. And so sometimes people come in with that symptom, actually, irregular heart rhythms. And then as the levels of urea go up, that in of itself can cause symptoms that are called uremia symptoms. And those include confusion, drowsiness, itching, actually, nausea, loss of appetite, sometimes vomiting. So those are some of the symptoms of really significant kidney dysfunction. So when it comes to kidney disease in older adults, so again, chronic kidney disease is defined by a GFR less than 60 milliliters per minute. And it is quite common as people get older. It's estimated to affect about 35% of people over age 65, and it does tend to go up as people get older. And then it's also fairly common for people to have these incidents of acute kidney injury, which can be a complication of, another health problem that someone is having, again, such as dehydration or a bad infection. So even though in most cases people are going to have a level of chronic kidney disease where they feel no symptoms at all, but even though they aren't experiencing symptoms, it's important to be aware of it if you have this condition, because you're going to want to take certain steps to manage it. And I'm going to talk a little bit more about evaluation and management. But some of those steps include knowing to avoid or minimize certain medications that tend to stress the kidneys, such as nonsteroidal anti-inflammatories, often abbreviated as NSAIDs, such as ibuprofen. And I have a video on those as well. Certain medications need different dosing once kidney function has declined enough. And in general, it's often appropriate to take certain steps to try to protect the kidney function that remains, to slow the progression, and to avoid, what we might call complications that result from having significant kidney dysfunction for a long time. So what are these stages of kidney dysfunction? So generally, they're defined as follows. There are kind of 5 stages of GFR. So normal is considered greater than 90. Stage 2 is 60 to 89. This is considered mildly decreased, normally not defined yet as chronic kidney disease, just kind of like mildly decreased, maybe keep an eye on it. And then stage 3 would be a GFR of 45 to 59. This is considered mildly to moderately decreased. Generally, people do not have symptoms. Stage 3B would be a GFR of 30 to 44, moderately to severely decreased. And then it's really once people get to stage 4 with a GFR of 15 to 29 that we consider that severely decreased. And even there, most of the time, something like dialysis is not needed. Stage 5, when the GFR is less than 15, would be more when people might be getting to the point of being in what's called end-stage kidney disease, of being in kidney failure, and needing dialysis to replace the function of the kidneys. So what you should know is that although there certainly are people who end up requiring dialysis or another treatment for end-stage kidney disease, such as transplant, the vast majority of older adults with chronic kidney disease do not progress to stage 5. So, what causes kidney disease in older adults? The most common cause is accumulating progressive damage over years and years to the kidneys due to high blood pressure and or high blood sugar, especially if the blood sugar is high enough to qualify for diabetes. It often takes years and years of having diabetes, decades of diabetes before the kidneys are severely affected. But diabetes is a common cause of chronic kidney disease. And then kidney disease can be caused by other problems. Sometimes people have had a bad infection and their kidneys haven't fully recovered. It can be autoimmune diseases. And then it can also be exacerbated by chronic use of medications that stress the kidneys, again, such as nonsteroidal anti-inflammatory drugs, such as ibuprofen. And then again, some other causes, contributors, these are a little less common, would be infections, either in the kidney or elsewhere, autoimmune diseases, blocked urine flow to the bladder. That can happen due to kidney stones. Sometimes it happens due to tumors. Sometimes it happens due to an enlarged prostate that's not allowing the bladder to empty. And then anything that causes inflammation can be a contributor, such as smoking. Obesity is actually associated with chronic kidney disease as well. Last but not least, I want to mention that aging is in of itself associated with a mild decrease in GFR. It's estimated at about 1% per year. Another estimate I've seen is, about a loss of 8 milliliters per minute per decade, starting once people are in their 50s. So that also can be a little bit of a contributor as well. So given all this, how does kidney disease, kidney dysfunction get medically evaluated? So most of the time, it's identified not because somebody is having a symptom or feeling unwell, but just because it's noticed on a basic metabolic panel that was ordered for other reasons, possibly as a check before prescribing blood pressure medications, because lots of blood pressure medications either affect the kidneys or affect electrolytes. So it's very common for us to order a metabolic panel as part of primary care. So one might notice, the GFR is lower than expected, or maybe the creatinine is elevated, or the BUN is elevated. And then further evaluation will depend on a couple things. So first of all, how severe does the dysfunction seem to be, right? Are we talking about a mild decrease in GFR, or are we talking about something more significant? Also, does this decline seem to be acute, subacute, or gradual? So acute means, is this something that we think came on just within the last day or two? Gradual would be something that's slowly been getting worse and worse and worse over months or years. And then subacute would be something that came up and has happened, within the range of, weeks to a few months. So how we think about the kidney dysfunction, how we monitor it, what next steps we take are going to depend a bit on that trajectory and that timing. We're also going to want to think about, well, what is this person's current health situation? What symptoms are they having right now? What's going on with them, right? Do they seem to be sick from something? Have they had a really bad round of heart failure where their heart has been pumping so weakly that their blood pressure has been really low? And is that affecting the kidneys? These are some of the things that we would be thinking about. We'll also look at the person's past medical history, illnesses and chronic conditions they've been diagnosed with in the past, or that might be active right now. And the general aim with evaluation is going to be to determine, what stage are they in? If it seems like it's chronic kidney disease, do they have albumin or protein present in the urine? Both because that gives us some thoughts regarding what might be causing the kidney dysfunction, and because that has some implications in terms of how we might try to protect the kidneys when it comes to medications and management. And ideally, the health providers would be trying to sort out what do they think is the underlying cause, and can that cause be treated or managed? So as part of this evaluation, generally health providers should be reviewing medications. Sometimes it's an actual medication that seems to have caused the problem, or there might be a medication that is making things a little worse. With older adults, especially if they're frail, we want to be thinking about hydration status as well. In some cases, it's appropriate to take a look at all this and say, hey, how about we recheck in 1 to 2 weeks, right? That's sometimes appropriate. And then additional tests may be necessary as well, such as a more detailed urine analysis. Sometimes they actually will look at the urine under the microscope to see if there are certain little substances in there that reflect what might be going on in the glomerulus or another part of the kidney. There are other more involved urine tests, specialized tests for certain types of protein that they might do as well. And in some cases, they might want to do an ultrasound as well. That can also shed light into what might be going on with the kidneys. And then you might be wondering, well, who does all this evaluation? So most of this can and should happen in primary care. Now, there are specialists in the kidneys. They are called nephrologists. And sometimes it is appropriate to refer to nephrology. So in general, this is especially relevant or important. First of all, if the GFR is really low, like less than 30, that might indicate it's time to refer to nephrology. That includes for people who have had chronic kidney disease for many years and are slowly progressing. Or if there are worrisome clinical features, like very high levels of protein in the urine, or, blood that seems like it's coming from the glomerulus. There are a couple other situations where it seems prudent to get a nephrologist involved. But much of the evaluation is done in primary care. And same goes for management as well. A lot of the management of chronic kidney disease also happens in primary care. So the mainstays include, first and foremost, if they can identify an underlying cause or trigger, they want to try to manage that for sure. But other things that are commonly considered mainstays, one is blood pressure control. High blood pressure puts stress on the kidneys, on those glomeruli, can cause ongoing damage. So it's especially important to control blood pressure in people who have chronic kidney disease. And then again, we want to avoid medications that would stress the kidneys, such as nonsteroidal anti-inflammatory drugs. We want to treat the underlying cause of kidney disease if possible. We want to make sure glucose isn't too high. That also stresses the kidneys. And then if it looks like the person has some level of albumin in their urine, which is actually fairly common, both in people who have diabetes or who have chronic kidney disease, even due to blood pressure, it can happen. Then there are certain medications that have been shown to reduce the progression of kidney disease in this case. And these medications include ACE inhibitors and angiotensin receptor blockers, which are often used for blood pressure control. And then there's another class of medications, SGLT2 inhibitors. That stands for sodium glucose cotransporter 2 inhibitors. And those are drugs that were initially developed for diabetes, and they're mostly still used for diabetes. They often end in flozin, such as canagliflozin, Invokana. would be a common one. And those have also been shown to be what we call kidney protective if people have the type of chronic kidney disease that includes a little bit of albumin in their urine. Otherwise, for chronic kidney disease, it's often sort of a monitoring form of management where we check labs a few times a year, kind of keep an eye on things, and try to keep the kidneys, operating as well as possible. Let me now talk about managing actual kidney failure. So the kidneys have an amazing ability to mostly get the key parts of the job done, even when filtration is significantly reduced. But sometimes when GFR gets really low, and by that, I mean really kind of like in the range of like 15 and below, that is quite severe dysfunction, and that can be considered kidney failure, and people start to get symptoms. And if that goes on and they develop severe symptoms, this can and does lead to death. And there are a couple pathways, specific pathways by which this can cause death. Unless that is, we use technological means to replace the function of the kidneys, to filter the blood and remove excess fluid and waste products and adjust all those electrolytes. And the process by which we do that is dialysis. So dialysis involves filtering the blood to remove the fluid and waste products. And there are essentially two key forms of dialysis. One is called hemodialysis. That's the form that is used fairly often in the United States. And then there's another form that's used a little less commonly called peritoneal dialysis, where they use actually the abdominal cavity, the lining of the abdominal cavity, to do a certain amount of that filtration. Dialysis can be done acutely in the hospital if somebody has really severe acute kidney injury. But what's more common is that when people have chronic kidney disease and it advances to a certain point, then a discussion about whether to eventually start dialysis gets started. So again, most people who have chronic kidney disease do not progress to needing dialysis, but some do. And so generally, the best practice is to discuss dialysis and start planning for it 6 to 12 months before it's actually medically necessary. This is partly to have time to think it through. This is also because if you are going to get ongoing dialysis for chronic kidney disease, you need to have a special blood vessel essentially created to do the dialysis with. You have to see vascular surgery to establish that, and it takes a while to set that up. So in general, discussions about possible dialysis are started once GFR is in the range of 20 to 25. People are often referred to nephrology once GFR is under 30. So, late stage 4, basically. Another option, once people reach this stage of kidney disease, is kidney transplant. And this can be an option even for older adults if they're otherwise in reasonably good health and are good candidates. That said, transplant is a very involved procedure and then requires a lot of care afterwards. Dialysis is actually can be quite burdensome as well, especially if people are older or frailer. So it's important to know that another option when people reach that stage of quite advanced chronic kidney disease is something that is called conservative kidney management. It's essentially a form of palliative management of the kidneys. And that's an option to know about as well. Can be especially worth considering if people are much older, much frailer, have lots of other medical conditions, and aren't likely to live a very long time. Because even with dialysis, if you have lots of frailty or chronic conditions, it can be hard to live a long time on dialysis. So in terms of, how kidney disease shows up specifically in geriatrics, again, many older adults do have some degree of chronic kidney disease. And often it's in the sort of mild to moderate range. They're not having any symptoms. And so, we're really kind of, monitoring, doing what we can do to protect their kidney function. Now, we do always want to consider checking kidney function if an older person develops new or increased confusion. This is a condition known as delirium, and kidney dysfunction is a potential, cause or contributor. So we want to be considering that. Because again, acute worsening of kidney function can be due to a variety of things that often affect older adults, such as dehydration, infections, urinary obstructions. Those can be caused by a large prostate, and much more. And then it's important to know that just because somebody's older, over 70, doesn't mean that dialysis shouldn't be considered as an option, or transplant for those older adults who do start reaching end-stage kidney disease. And those can be burdensome. So in geriatrics, because we tend to be especially likely to be caring for people who are older, frailer, have Alzheimer's or another form of dementia and so forth, we do often consider conservative palliative approaches for end-stage kidney disease, because it's been estimated that the burden of going on dialysis is similar to having cancer. It's a lot of medical care, it's a lot of visits, it's a lot of stuff. And so we just want to be mindful and thoughtful about going that route, and make sure people know that it's not the only option. It's often possible to keep people actually fairly comfortable, even when they have very advanced kidney disease as well. So given all that, if you have questions about your kidney function or chronic kidney disease or anything regarding the kidneys, what should you ask your health providers? Well, first and foremost, I would say ask, can I have a copy of my lab results? Keep a copy for yourself. I think it's just great to have copies in general. And take a good look at it. And if you see that the eGFR or any other results are abnormal, is this by a little bit or by a lot? How does it compare to prior results? Can you get those prior results from your health provider? Can you review the results with them and ask them to explain to you what they think might be going on? And then especially if the eGFR is less than 60, or if it seems like a sudden, pretty significant drop, what do they think is the likely cause? What is their plan for further evaluation? What is their plan for managing this, monitoring this, helping, protect your kidneys and reduce progression? And what is the plan for monitoring the numbers? When are they planning to check on this again? So with that, I'm going to wrap up this episode. I hope you found this helpful. If you had any questions about kidney disease, and if you did, if you're here on YouTube, please go ahead, give it a thumbs up and subscribe. It does help more people find the channel. If you've been listening to the audio version on the podcast feed, come and take a look at the video if you get a chance. You'll see my key points being displayed on the screen. And again, another option to support my work is to consider joining the channel as a member. Just click the join button below the video. So thank you once again, and I look forward to seeing you again soon on an upcoming episode of the Better Health While Aging video podcast.